Good morning, everyone, and welcome to our second panel on the generic drug distribution system. My name's Darius Lakdawala. I'm a professor and health economist at the USC's Schaeffer Center. I'll be moderating, and it's my pleasure to welcome a distinguished group of panelists to the discussion. First is Christine Simon, who's the Senior Vice President of Policy and Strategic Alliances at the Association for Accessible Medicines, previously known as the Generic Pharmaceutical Association. Welcome, Christine. Next is Tom Moriarty, who's the Executive Vice President, Chief Policy and External Affairs Officer, and General Counsel at CVS Health. Welcome, Tom. Doug Hoy is the CEO of the National Community Pharmacists Association. NCPA represents 23,000 community pharmacies and their pharmacists. And to reintroduce Matt Isles, who's doing double duty today, recall Matt is the Executive Vice President of Policy and Regulatory Affairs at AHIP. And we're also joined by Steve Lieberman and Paul Ginsberg, the co-authors of the paper we just saw. So welcome everybody. We're looking forward to a great discussion. So there's a lot to talk about here. Before we get to the policy questions, I'd like to begin by getting everyone to weigh in on what they think is the size and scope of the policy problem to be solved in the generics drug distribution system. So from the policy barometer here is, what are the prices that end users are paying for generic drugs? So end users being consumers and other third-party payers like employers. Are these prices close to being competitively determined in the sense that they can't be driven any lower without making people go bankrupt? Or is there a lot of room for them to fall? So Steve's and Paul's study suggested that ingredient cost is a relatively small fraction of the price that end users pay. Does that mean we have room to squeeze these down, or is that the real cost of delivering drugs? So let's go around the panel and get people's thoughts on the scope of the problem. Christine, what do you think?
Sure, thank you, Darius. Thank you, Darius. And thank you, Steve, for the paper. A lot of good work being done on this topic. Certainly no shortage of panels, presentations, papers, and policies. So obviously a great deal of concern out there. You know, we in the generics industry are really happy to be a key part of the solution around drug pricing. You've seen some numbers up there. We just released our Access and Savings Report yesterday, updating the numbers. So right now we are 89% of the scripts, and we're only 26% of the costs. And, you know, when you look at a variety of policy solutions, and I must say this one is at least doesn't impose any burdens directly on the generic manufacturers, so thanks for that. So we do appreciate that. You know, the one we're discussing today really deals with a lot around MAC pricing and sort of the relationships between PBMs and plans and pharmacies. So we're a little bit on the sidelines. But I would say that, you know, when you look at the idea of less than $1 reduction having a $4 billion savings, that's good. But, you know, we just did a paper last week, released a paper on how the abuse of restricted distribution systems, or REMS, patient safety programs by some brand consumers is protecting over $22 billion in profits. I mean, we feel that there are, you know, potential for additional competition in the marketplace. There's a little discussion of that in the previous panel. And it's not the silver bullet, but the more generics you get on the market, the more competitors you have in a therapeutic class, the more patients and the entire system saves a tremendous amount of money. So I think, you know, this is one area of focus, but, you know, perhaps a better area of focus, or a more impactful area of focus, is if we're 89% and 26% of the costs, then others are, you know, 74% of the costs with only 11% of the scripts. So we need to be focused on specialty medicines and higher cost medicines. We need to be focused on increasing opportunities for biosimilars competition, and some of the other I think ways to really drive down, you know, costs. This is nibbling at the margins. It's not without value, but at the end of the day, I think there are bigger fish to fry.
Yeah, I guess I would say the market really does function very efficiently here. I think, you know, there are a number of public data points to show this, and the various drug trend reports that have been put out there will reference this. You'll see within those the impact that generic discounting drives in reducing overall drug spend in this country. It's dramatic in terms of that impact, and that's because deeper and deeper discounts are being driven around generics, and it is the lion's share of dispensing. While it's not the lion's share of spend, it has a disproportionate impact on the ability to reduce that spend. The other aspect to this is, while there's reference to rebates on generics, I do think the lion's share of generics being purchased do not involve rebates. In fact, they're direct purchasers and straight discounts, and those straight discounts do get included in the publicly available databases. So put the potential flaws of NADAC aside, there are other state Medicaids that require direct acquisition costs to be reported. We report that. So that clearly influences what happens, and that information then is used to determine the MAC, which is essentially the generic reimbursement for retail pharmacies. The other element of this is, the reference to a potential conflict at the PBM level. That issue has been investigated 3 separate times by the Federal Trade Commission. In 2003, under the MMA, there was an investigation done on that, whether mail-order pharmacies being owned by PBMs and having them within the same house. Clearly found by the FTC that is not a problem. In fact, it leads ultimately to lower prices. It was looked again in 2007 and again in 2011 with the same result. And then we'll get into this later, but I think there are elements in the marketplace that actually are addressing this, and that is the availability of 90-day prescriptions at retail. And that 90-day prescriptions are actually at the mail order discount, not at the retail discount. And that discounting is substantially deeper than straight line retail. So there's a lot happening in the marketplace that I think has addressed this issue already. And I know Doug will have some insights as to whether or not the reimbursement for generics at retail is appropriate or not.
Thank you, Tom. Thanks for that setup. We agree that this is an important issue. However, as far as the magnitude, as Christine said, yesterday there was a hearing in the Senate on prescription drug pricing, and it was stated there that 10% of healthcare costs come from prescriptions. That's brand and generic. And if you look at the 27% of overall healthcare costs, you're talking 2.7% of overall healthcare costs come from the generic side, which is a very small amount. And even 10%, if you look at overall prescription drug costs, 10% out of all we spend on healthcare is a very small amount for arguably the best investment that we have in healthcare. So while this is very important, when you look at whether it's the 2.7% of generic or the 10% overall on the retail side, there are other ways to get greater value from the healthcare side. It's been mentioned a couple of times, the dollar reduction resulting in a $4 billion savings. The market does operate very efficiently, and from our members' standpoint, perhaps over efficiently at times. So reimbursement for us, our net EBITDA, we have a sort of an EBITDA, is around 200 basis points. The average prescription drug cost in an independent, I think this is true for chains as well, is about $55 to $60. So based on that, that's about $1.20 that at least the average small business owner pharmacy is clearing. So you take $1 and you're putting 20,000 pharmacies potentially out of business. So that dollar, the margins are so small that, even though it sounds like, oh, it's just $1, it's very important. Also, again, on the efficiency side, because of the MAC pricing really dominates the way generics are configured. AWP, as Stephen said, is not really that relevant, although it's increasingly becoming relevant. But MAC prices are often used, and those MAC prices, some payers are paying pharmacies below their acquisition cost, not below their cost, below their acquisition cost. There's one payer, one of the large PBMs, pays the pharmacy below their acquisition cost 15% or more of the time. That's atypical. It's typically 5 to 10% of all prescriptions, generic prescriptions, are paid below cost. But that's an important fact. So we're seeing, I guess, some of that market efficiencies already. One other thing I'll mention before passing it down to Matt is the conventional wisdom that pharmacies make more on generics than on brands has really been stood on its head in the last, I would say, 2 to 3 years. That was true for many, many years. that there was an incentive. It was a win-win-win for the plans, for the patient, and for the pharmacy when a generic product was dispensed. That is no longer always true. In fact, it's often not the case. There are many situations in which there is higher dollar reimbursement for dispensing the brand. Some of that is due to the generic deflation that has taken place, especially in the last couple of years. But the advent of generic deflation has really drastically changed the marketplace and made the pricing even more aggressive on the retail side. So again, thank you for the invitation to be here. I appreciate it.
Thanks for not kicking me out after the first panel and having me back. So with respect to the paper, I mean, there's a lot of interesting concepts in it. And I'd say from the health plan perspective, in general, we like more information to be able to, understand pricing situations. That said, I'd say our biggest concern really is around, at least that I hear from our members regularly, is sole source generics and what's happening in the market. And I would be concerned, I'm not quite sure, would have to think through all the implications throughout the distribution system, but anything that potentially could have additional downward pressure that would lead to longer term having more sole source generics, and I don't know that would actually be an outcome. I have to think through what would happen, that would be a negative thing for the healthcare system. Again, just to sort of bring it home to a patient level, I mentioned my son earlier. One of the other prescriptions he got yesterday was for a generic minocycline, now sole source, $200, right? And it's an old drug, because there's not a lot of competition when you only have one there. So, what I hear consistently again from the health plan side is, how do we ensure FDA gets generics without a lot of competition or any competition out there? How do we get them approved more quickly so that we can see the dynamics that we see with multi-source generics, which the savings are enormous when you get down to commodity price levels that are much lower.
Thanks. Steve, what are your thoughts on the discussion so far? Okay, Paul?
Thank you. Let me try to run through a couple of things. In some ways, Paul and I took the opposite approach of Neeraj, who started at a very global level with a very aggregated data. We tried, and there are clear data limitations, but we tried to look in a very detailed way at a very specific problem. So no, we're not trying to deal with the fact that there are very high-cost specialty meds that are consuming a large portion of that 74% of health spending. No, we're not trying to deal with the fact that there are things that are delaying generic introduction or generic competition. No, we're not dealing with the fact that there are supply chain disruptions in the manufacturer side where you have single-source generics or inadequate supply of generics. What we are focused on is looking at the distribution of generic drugs, which are a high-volume commodity. And in answer to your question, I think it's I would say that with the exception of the oddball circumstances where you don't have effective competition, this is a very effective market. In the slides, and I didn't say this, our estimates are well under a third of what pharmacies get reimbursed goes to pay the generic manufacturer. The lion's share of that is retained by the pharmacy. In our paper, we are pretty careful to footnote our sources. We would love to have more data and transparency in this area. But just to quickly respond, there's an excellent study that the Department of Insurance in the state of Washington published in late 2016, where they looked and had a fair amount of transparency into these issues, including things like the level of appeals of where MAC pricing was below acquisition cost. That 2016 study explicitly stated that pharmacies make more money on generics and brands. The MAC pricing, which I didn't discuss, be happy to, we discussed it briefly in the paper. MAC pricing, according to that study, on average, was significantly above NADAC, which is significantly above dead net prices. That is what net ingredient costs are. And I guess the last thing I would say is, I think from Paul and my perspective, given that we believe it's a very competitive market currently in place for multi-source generics, and they are essentially commodities, we don't think our proposal will change the price in those competitive settings that manufacturers receive. We believe that we're squeezing margin out of the distribution system. Thank you.
Thanks, Steve. Paul, anything?
No, Steve covered it well.
Great. Well, so here's this has been an interesting discussion so far, and many people have been pointing out that the generic drug distribution system is a reasonably efficient system. In fact, some people have said it's a highly efficient system. Yet, if one reads the news, and not just the news, but pronouncements of policymakers, for instance, there's been a lot of focus on these single-source generics as a location of rapid price increase. Scott Gottlieb has made increasing generic competition one of the pillars of his approach for cost containment at the FDA. So what are we to make of these apparently disparate facts? On the one hand, is it the case that we have a really well-functioning market? Or could it be that we have historically had such a well-functioning market, but there are threats looming on the horizon, or are these threats overstated? What do people think about that? Christine, what are your thoughts on the debate around the generic drug industry?
Well, I think, we're talking about several different components here. The distribution system versus the market overall versus sole source generics. So talking about the last one first, well, first of all, let's not be confused about what's a sole source generic and what's not a generic at all. So I'll just say it again because I say it all the time. You all can say it with me. Daraprim is not a generic. Daraprim has never been a generic, never was a generic, still not a generic. It is a drug that was approved under a new drug application. That makes it a brand. And it never had any competition. Its patent expired. And no one else came into the marketplace, so it jacked up its prices as a brand. So not a sole source generic. There are sole source generics that do have, that have no competition, and simple Econ 101 will tell you that usually results in higher prices. And there are potential policy solutions for that. We're very excited to have Dr. Gottlieb at the FDA. He has a very substantive understanding of the generic drug landscape and the marketplace, and clearly is interested in many of the different ways to increase competition in the market, some of which I touched on, for example, the abuse of restricted distribution systems so that manufacturers can't get access to samples and make the drugs in the first place, the generic drugs. So there's a lot of potential there. The distribution system, again, most of what we're talking about and what Steve touched on in his paper occurs after the drug has left the manufacturer and is making its way through the supply chain, so I'm not really going to speak to that, but I will say that Doug was right in pointing out the deflation. Generics have actually been in a deflationary trend with about 8% deflation over the past several years, and it is, there's been consolidation at all levels of the pharmaceutical supply chain, and there are impacts from that consolidation. And so we do have to be careful that we don't try to drive down some of the incentives in such a way that generic manufacturers end up exiting markets because they simply can't afford to stay in them. So that's something we want to have: sustainable competition, sustainable reimbursement, so that we can, keep a balance in the marketplace and ensure that patients can have access to affordable medicines.
I would build on Christine's points. I think, if you look what is happening at the FDA and what Dr. Gottlieb has talked about is really a twofold approach. One is clearing out the backlog of existing generic applications, but also creating a more efficient pathway for newly filed applications. And that element is very, very important, and Christine will know this better than me, but I think last year you saw a decline in the number of newly filed applications, which should be concerning to all of us from a market access and pricing perspective as well. So it's both ends of the equation that need to be focused there. And then the other element I'll bring up, which is a little outside this panel, but I think is very important as well, is the role that biosimilars, which are essentially, for the layperson, generic biotechnology products. generic specialty products and the role that they play. And we really should look at what's happened in Europe and Japan with the creation of a pathway for the introduction of those products and how far behind we are here, because when we look over the next several years where the lion's share of drug spend and medical spend will be going, it is going to be on specialty drugs and those biotech drugs. And if we don't introduce competition into those spaces, what we're talking about here will pale in comparison.
I want to comment on the one of the things in the paper I think is really spot on was the imperfect information, the asymmetrical information, which we think is very true. And because this marketplace is moving so fast that the information, not only is there imperfect information, but the information gets dated very quickly. So if you know what happened in 2014, you actually know what happened in 2014. It may have less to do with what's happening in 2017 and what will be happening in 2018. So for example, the MAC pricing above NADAC, we don't know what MAC prices are invisible to retail pharmacies, and they change from hour to hour, pharmacy to pharmacy, minute to minute. So there's really no way we can know how MACs compare to the NADACs. But the information does become very dated. On MAC appeals, we're not really able to do MAC appeals very often because we actually get threats from PBMs if we give too many MAC appeals. So there's that challenge as well. But with the generics, again, there's been a major shift. Generic inflation on certain NDCs was occurring rapidly, throughout the marketplace. Some of our numbers show, using NADAC data, show that 400 NDCs went up over 200% in 2014. But that's been going down. There have been market corrections, and it seems like, in fact, in looking at that same list today, the number of NDCs that are going up over 100%, it's still a lot. I think 60 is the number that we calculated, but it's a fraction of what it was a few years ago. So while, whether it's the digoxin or the doxycycline example, the clomipramine, there's lots of examples, we're seeing fewer and fewer and fewer of those. Not to say the problem's been completely corrected, but the marketplace has adjusted. And the marketplace has, for whatever reason, those prices were going up 500% overnight, or whatever the percentage was. That seems to have abated. Again, very different, though, than it was, say, 2 or 3 years ago. So the market is constantly adjusting.
I think Doug's right. I know I still hear it from our members, on occasion. I think they would say the market overall, functions very efficiently. And to Doug's point, I'd say 18 months to 2 years ago, I was hearing a lot more complaints about generic drug price inflation and generic drug costs increasing, rapidly, even to double-digit levels, but again, on a relatively low base. And I think Tom made the good point, right, that it's important to focus and find efficiencies wherever we can, but to the extent we can find, the really big savings, I think that's where, either through getting additional generics approved to improve competition in those areas where there's backlogs and only sole source, or to the bigger area of biosimilars and thinking about, that certainly that would be our priority. But again, we're all for efficiencies and anything that would improve affordability overall.
Let me say something about efficiency. When I think of distribution, one aspect of efficiency is for drugs that are where there's no shortages at the manufacturer level, are they getting out to the consumers that need them? And it seems though, yes, they are. The other aspect of efficiency is, are the prices too high? And I think there's real evidence that Steve presented that, in a sense, at the pharmacy level, the prices are a lot too high, and that there really are opportunities, I think, above competitive returns are being earned, and that we got some of the tools to try to foster greater efficiencies. There are others. Health plans can pursue narrower networks of preferred pharmacy. This would foster competition at the pharmacy level. But I think there's a lot that can be done here.
I want to, oh, sorry,
just-
go ahead, please, Steve.
I want to add one quick point, which is, interestingly, an outgrowth of our proposal, which is essentially to get real-time, weekly or biweekly updates on pricing. If there are, in fact, price spikes from generics, that reporting would actually make that known. So it's a way to actually deal with the rapid cycle of pricing change.
So I want to pick up on two points that Paul raised and get people's thoughts on them. The issue of pricing at the pharmacy and also of shortages, because there's been a lot of attention paid to these two issues in different contexts. Doug, what are your thoughts on Paul's comment regarding the pricing at pharmacies? How would you respond to that comment?
Well, you know I'm going to disagree with that.
Trying to stir up some disagreement here.
Yes. No, we obviously disagree with that. The example I gave where the average net profitability for prescriptions about $1.20, I think speaks volumes. We would also, disagree very strongly with the WAC minus 70 assertion that was made in the paper. That would say that that a rebate is 70%. I may be doing the math wrong, but my basic math, I think, says a rebate is 70%. The rebates do vary from product to product, which is very true, but at least from the reports that we get, and we don't get reports because we're a nonprofit trade association, but just anecdotally, what we hear in the marketplace, the rebates are nothing like that. So I think the 1/3 is the cost of the drug and 2/3 the pharmacy makes on it. We would strongly disagree with that. Another important thing to mention, though, is sometimes when generic profitability is talked about, it's talked about in percentage terms. So, for example, use an inexpensive drug like hydrochlorothiazide, which is for a water pill for a diuretic for blood pressure. That's a very inexpensive medication. And so one could say, gosh, the pharmacy's making 100% margin on this drug. Well, yes, but the product costs 45 cents. So because generics in some cases are so inexpensive, a cost-plus mechanism actually is more attractive and makes more sense to pharmacies. Now, that changes a lot when you start talking about biosimilars and specialty, because then you're talking about 5, 10, 15, 25,000 or more dollar drugs. But a cost-plus methodology, which is essentially what many of the state Medicaid programs have done, actually makes a lot of sense in many ways.
Matt, what are your thoughts on this? Do you think that pharmacy prices are about where they should be for generics?
I'd say overall our members are not, that's not their big concern, certainly. I'd almost pose a question back maybe to Steve, which is, let's say under the price reporting system we do get a sharp spike of generic drug price. I guess the question is, what can really be done about that, right? So that you learn that there's a sharp increase, right? And with the generic, there's probably not an alternative out there. We're probably seeing a spike for a reason. A health plan probably can't change their formulary or wouldn't change their formulary to exclude coverage. It would be important information to know, but I'm not quite sure what we could actually do with it.
I think there are two implications of the scenario you posed. One is you don't want pharmacies to be upside down when they're acquiring a drug. So one would adjust whether it's a MAC price or whatever the other reimbursement is. The other is it would be an early signal, for example, to the FDA of some kind of disruption in the supply chain, either an ingredient shortage, a manufacturing problem, so it becomes an early warning system. It is, again, not a panacea, but it starts to address specific issues. And just one other quick point, I entirely agree with Doug's point about it's much more useful, I believe, to look at dollar markups rather than percent margins, particularly when you're comparing vastly different products or you're talking about a shortfall on a $3 ingredient. To make up a $1 shortfall requires a huge percentage increase. I would commend to everybody a 2004 report that CBO did, and CBO has a unique advantage because outside of the OIG and the people in CMS who actually administer the Medicaid drug rebate program, they're really the only people who have access to AMPs, to dead net prices. And I hope they have a 2007 report that somewhat updates that, but the 2004 report makes the point about markups versus percent margins. My hope is that my former colleagues will update those reports, because it is very difficult to get good information to inform policymakers in this area.
I guess I would just add, since this is a broader policy discussion, two policy implications of further reductions in reimbursement. And one would be the formation of networks and the availability of retail pharmacies to dispense. And I think, Doug will weigh in on this as well. But you're reaching points now where your reimbursement is below your ability to cover your costs. So you see pharmacies making decisions that they won't participate in certain networks because of reimbursement just isn't enough. The second is, as we engage in this value-based reimbursement discussion, we really need to focus on and highlight the role of the pharmacist. And the reimbursement here is all about the dispensing reimbursement. It's not at all about the cognitive skill sets that pharmacists bring to bear in the healthcare system. And what is the reimbursement appropriate for that? And, all studies show that pharmacist engagement with patients increase adherence to medications by 3 to 4 times any other engagement. And we should be looking at a system that actually compensates for that type of engagement in a way that truly compensates for the value being driven as well. So just two broader policy points that we should keep in mind as we go down this discussion.
Thanks, Tom. And I do want to get us to the other point that Paul raised, because we haven't talked about it so far, and it's not strictly, I guess, a question of distribution, but there's been a lot of attention paid to what appear to be growing shortages in generic drug manufacturing and distribution. Whether that's real or perceived, I guess, is the question that I'd like to pose to the panelists. Are we seeing more shortages for essential generic medicines today than we did 15 years ago, or not? And what do you think of the implications? Why do we have a lot of attention paid to this issue? What are your thoughts on that, Christine?
Drug shortages can be a problem for sure, and there are different factors that create shortages. Sometimes it's a ingredient sourcing issue, getting the API and getting it to the facility. Sometimes it's a result of FDA inspections, shutting down facilities. That's something that, when we negotiated the first User Fee Act for generics, and now we're, of course, hopefully wrapping up the second round for generics and all of the UFAs this fall. But we wanted more, and we paid for more foreign inspections of facilities, because that's critically important, and patient safety is obviously paramount. So that can be a reason for shortages. I don't know that they're on the increase as much as we are keenly attuned to them, maybe now more than we had been in the past, and they're more easily reported, and the implications are perhaps more widely vocalized. So, and that's not a bad thing, but in terms of focusing, there are many things in place to address drug shortage issues, and it's just an ongoing challenge that I think the whole supply chain has to deal with. I can't speak to specific products or manufacturers, but I know that our manufacturers work very hard to avoid shortages.
Yeah, I just point out that unfortunately, I think your question has much more to do with what I'd consider the manufacturing supply chain than the distribution chain. And our paper was unfortunately focused on the distribution chain.
Okay, so suitably chided. Let's talk about the price transparency proposal in the study that Steve presented and that he and Paul prepared. So let me kind of open that box up for everybody to talk about, and I want to maybe consider a couple of angles on this question. First of all, to what extent do you think greater price transparency of the form indicated? To what extent would it reduce the prices that end users face for generic drugs? And is it, in your view, the first order policy reform that's needed in the distribution system? And if not, what other reforms would you consider? So maybe let's begin with Matt and work down the table.
Yeah, I mean, we're definitely supportive of more price transparency to help inform decisions at the plan level. Question is, what does it get us at the end of the day? Not that, again, anything that can improve affordability that flows down into consumers and premiums and co-payments, I think is potentially a positive. Still trying to digest how far the proposal would go to actually accomplish that. Again, anything at the margins would be helpful, but what would it actually mean in terms of what the end user pays at the pharmacy, the consumer, or what would the impact be on premiums and overall affordability? Still a little questionable, I think.
Well, Matt, what do you think would be an alternative? If you could snap your fingers and change one thing in the drug distribution chain, what would it be? And I'll let you think about it, and we'll go down the rest of the table on this question regarding price transparency. Doug?
I think the proposed solution is, I think transparency overall is important. So that's almost a silly thing to say. Of course transparency is important, which we don't have, again, the imperfect information that we have right now. I think what the paper, as I understand it, really it seems very tactical versus strategic. And that sounds really critical. I didn't mean that as quite as harsh as it sounds, especially with the two authors right here. But it would only address one, I don't even know if that it would address, it would only look at one part of a much broader problem of the lack of transparency that we have in our healthcare system. Again, it's 2.7% of the overall healthcare costs. So trying to get pure transparency there first doesn't really make a lot of sense to us. If we're going to look at that 10% part of the overall healthcare spend, which goes to retail prescription drugs, we would suggest looking more on the PBM space, because there is a lot of opaqueness in that area rather than in the prescription drug pricing.
Let me just quickly follow up on that point, Doug. We haven't talked about that, and it's the issue of PBMs in the distribution system, and Tom is going to get a chance to weigh in on this as well. So there's certainly been a lot of criticism that the incentives for PBMs encourage higher list prices because they get rewarded on the spread. And just confining your attention to the generic drugs, given that that's our remit here, do you think that's an issue here that we should be particularly concerned about in the generic drug space? And what would you view as a potential solution to it if you do think it's an issue?
Yeah, it's definitely something that needs to be looked at as well. There's a lot. It's a different mechanism. So the pricing in a PBM, and of course, in a PBM contract for generic drugs is different than on brand. So it may not be as rebate driven as it might be on administrative costs or on an AWP minus or a different max schedule. There's no transparency into any of that. But because the AWP spread is so wide on generics, any manipulation of AWP of the second part of that AWP minus can lead to some pretty lucrative profitability on the PBM side, and especially when they're the pharmacy, the price setter, and the price taker. So I definitely think that's an area that needs more insight, more focus. It's just tough to get. It's tough to get data. Very tough to get data from that side of the house.
Tom?
Yeah, I'll follow up on that. As I indicated in my opening remarks, the issue of the conflict has been looked at 3 separate times by the Federal Trade Commission, and the issues haven't changed. And since 2011, 2012, you've had a highly deflationary market in generics, as Christine can confirm. You have perhaps even higher competition in the PBM space, where you have very sophisticated purchasers like Matt's members who have very, very smart people doing that negotiation. They also leverage a highly informed consultant community. And as a result, what you see is the net effective pricing has in fact compressed and decreased. And I think that's demonstrated not only by the trend reports, but also by the fact that you have mail order basically flat to declining now from a client perspective. And that's because, and you actually now have more increased discounting at mail order to try and maintain that share. And that's driven by a number of different issues, obviously the advent of 90-day prescription availability at retail and other things. So, this issue has been looked at any number of ways, both at the federal and state level. And I think the data bears out how competitive the marketplace is and the value that ultimately is delivered to Matt's clients, or members rather, employers, state and federal governments, labor unions, et cetera. So.
I don't have too much more to add to that. I mean, we do think that it's a very efficient marketplace, and sometimes, from our perspective, a little too efficient. And there are other, as I said, other ways to try to reduce costs and increase competition in the marketplace. But you can't get blood from a turnip, so you do need to sort of pick where you really want to focus policymakers and policy solutions. And this has been an interesting exercise, and I think the paper did a great job of elucidating the market and really looking at different factors. But I think you have to come up a few 100,000 feet to the bigger picture and focus on things that will really drive savings.
So let's open up for a few audience questions, then we'll wrap up. Please, over on the right over here in the black.
Hi, I'm Sydney Lepkin from Kaiser Health News. I have a question about generic competition, actually related to a different middleman that we haven't really discussed here, which is GPOs, which is if I am a generic manufacturer and I want to sell a product to hospitals through a GPO, but the fee to be part of that GPO is something that I can't afford, and there aren't that many GPOs. Could that force me out of business? And if so, how widespread of a problem is that as it relates to competition with generics?
So on the hospital GPO side, I'm going to have less insight into that. I can share with you on the retail pharmacy GPO side, but it's a different model than on the hospital side. So I don't know that my answer on the retail side would really answer your question.
Yes, thank you very much. I have a question that relates to the end user distribution and technology software and apps. It's my impression that for the gentleman who got the $600 ointment, that there is not software or an app that you could use that plugged in the name of that prescription and found out the range of prices in a certain geographic area, say Washington, D.C. And the same, there wouldn't be an app. So my question is, if at the end user consumer level, there was something that said, if you want this prescription in this geographic area, these are the 8 different prices that you would pay, sort of like you could do an appliance, would that help in a sort of trickle down backwards? If you follow my question, you can get 6
thank you.
prices
That's right.
for a stove.
So the question is about price transparency for consumers. Steve, do you want to?
No, I'm talking about an
So,
app.
so
Right, we understand.
two comments. One, Medicare for Part D has Plan Finder, which essentially does that. Second point, what you get out of that app, I assume, is what the plan would charge the beneficiary, not what the true cost of the good is. So again, the question of, as when we have a glossary in our paper that sort of unfortunately tediously goes through the different price perspectives. And so the question is, are you trying to get transparency about the cost to society or the cost to the consumer? And those are different measures. And I assume that one could take, there's some data issues, but one could take Plan Finder and make that mobile. But again, the question of whether people use it.
If I could add something, I think when you mentioned that the Plan Finder, not too many people use it, this unfortunately is the story throughout healthcare, that some very sophisticated tools have been placed in front of consumers, often by insurers, to get, negotiated prices. Different providers, they don't use them. The upshot of it is that there needs to be other ways to foster competition in the market. Often network strategies, reference pricing, far more effective than just providing a lot of information to consumers.
Doug, I know you want to respond, and you'll get the last word.
It's not an app, but as far as cost savings, it's your local pharmacist. And I know that sounds something exactly like I would say, but in the example of the minocycline, without divulging too much HIPAA-guarded PHI, my son also takes minocycline.
Where are you getting it?
We'll talk. My local independent community pharmacy. Where, oh my gosh. That's tape too, but no, my local independent. And I am a pharmacist, and so when the prescription was written, the prescriber, whatever came up on their handheld, and they wrote it for the tablet. And I know there's a tablet in a capsule. Because I'm a pharmacist, most consumers are not going to know that. And so when I took it in, I said, hey, I know the tablets are sometimes more expensive. Would you check out the capsule? Saved more than half the cost on the drug because I got the capsule instead of the tablet. That's knowledge that I have because I'm trained. There are 300,000 retail pharmacists in the country who have knowledge like that and who can help. Like in a steroid cream, there's quite a range of different steroid creams, ointments, creams, lotions. And so the pharmacist can provide an alternative, especially in those cases, which are becoming more rare, where the product has gone up 500% overnight. And that's actually what happened during the time when it did.
Thank you very much, everybody, and I'll turn it over now to Paul for closing remarks.
Yeah, I want to thank first the paper presenters for the great job they've done, all the panelists who really provide a great deal of insight to you, the staff who made this run flawlessly, and also the gift from Leonard Schaeffer to USC and Brookings that supports the Schaeffer Initiative for Innovation in Health Policy. Thank you very much.